精神疾患と物質使用障害の併存についてということで、キャロライン・セーラム先生にお話をいただきます。ドクター・セーラムの、ご紹介をシャロン先生、チャネル先生にお願いしたいと思います。
Good afternoon. I will also introduce Caroline. Associate Professor Caroline Salom is a group leader and principal research fellow at the Institute for Social Science Research at the University of Queensland. Her research covers public health, epidemiology, mental health, and addiction medicine, with interests in comorbidities, social disadvantage, and evaluation of health, justice, and social support programs. Current projects include drug trends, domestic and family violence, and comorbid substance use and mental health disorders, especially in young people. Her work includes research and evaluations totaling over $17 million that has been commissioned by governments, community-based organizations, and the private sector. Thank you for joining us, Caroline. Over to you.
Thank you very much, everyone, and thank you very much for the invitation to join you today for this important webinar. I would like to introduce myself briefly and then talk a little bit more about my broad area of research interest. And then I look very much forward to hearing your questions and discussing this work with you. So very briefly, who am I? My original background is in medical research. I studied gene regulation in chronic diseases. So I have moved since then into working with non-government alcohol and other drug services in research, in program design, and in staff training. And I earned my PhD in the epidemiology of co-occurring substance and mental health disorders. So my current work, as Chanel said, is very much about the epidemiology of substance use and mental disorders and how our social and health systems work to support people with these disorders and associated disadvantages, because we know that people experience great deals of disadvantage in this area. My current work and where I will be drawing from is primarily in the drug trends research program. Now, I know Chanel spoke to you earlier today about the very important global drug survey. Drug Trends is a research program based in Australia, which asks about the trends in use, harms, and other problems associated with substance use, but it uses face-to-face interviews with people who regularly use drugs rather than an online methodology, which gives us a little bit more time to explore some ideas with people face-to-face. I also work with the World Association on Dual Disorders, which is an international organization that focuses on comorbidity. And I'm very interested in cohort studies, so what happens across the life course for people, and work with collaborators in Mexico, in Spain, in Finland, and in the United Kingdom. Not yet in Japan, but I will be very interested to continue conversations. And very importantly, I do a lot of work translating our research knowledge or putting it to work to use it to understand best how our social justice and health programs work to support people who have these needs. And we do this by evaluating programs and policies. So a brief overview of what I would like to talk about today. I'd like to talk about what comorbidity is, how we define it, what names we use to describe it, and which disorders are typically included. Then I will look briefly at how common it is in both general populations and some specialized populations, why it's important to consider this coexistence of two disorders in one person, both for the individual person and both the treatment systems and the practitioners who are involved, and then think about how we best reduce these harms and provide treatment and support for people, and what we need to do this. So importantly, names are important because the language that we use to describe people who use substances and who experience mental health problems are very damaging if we use the wrong terms, but they can also create confusion because famously one of the English literary agents suggested that language is a universal construct that divides us very badly. So typically the European Union's drug agency, which used to be called the EMCDDA, uses the term comorbidity, and that's often used in the ICD classifications. However, there is no direct classification in the ICD-10 for comorbidity. It's also referred to as co-occurring disorders, and so SAMHSA in the United States often uses this term. The World Health Organization talks about dual diagnosis. Many of the Latin countries where I have collaborators talk about dual pathologies. And then after some extensive collaboration and consultation, the term of dual disorders has been adopted by the World Association on Dual Disorders, but it's also used by the United Nations Office on Drugs and Crime and the World Psychiatric Association. So some of the reasoning behind this is that we need to have some sort of specificity so that we know we're talking about mental health disorders and substance use disorders rather than coexisting other physical health disorders. Typically, the languages that we use don't include the co-occurring physical health disorders, and historically we haven't included other behavioural disorders such as eating disorders or gaming and gambling disorders, although this is starting to change. The other thing for us to keep in mind is that disorders are not always diagnosed, so people may have a number of different disorders present in their lives at the same time. Not all of them have been actually diagnosed by a clinician, and so the dual diagnosis phrase is less accurate then. So how do we define it? The definition that was arrived on by the consultation that was done by the World Association is one or more diagnosed mental health problems that occur at the same time as problematic drug and alcohol use. So this consultation, which was largely with psychiatrists, I have to say, has suggested that the mental health problems need to have been diagnosed, but it's suggesting that the drug and alcohol problems may not yet have been diagnosed. Some of the other things that we need to think about are the care that we must take talking about defining the same time. Because of the relapsing and cyclic nature of mental health and substance use disorders. So often we will say the two disorders occur within a 12-month window, so within 1 year. The other thing that we need to keep in mind is that mental health disorders often present earlier than substance use disorders. So, for example, anxiety-type disorders like OCD and generalized anxiety disorders will appear before or around the age of about 15 years. Substance use disorders will typically arrive a little bit later, so in late adolescence, and one doesn't always precede the other, so you don't always have anxiety and then substance use disorders, because you can also have comorbidity of substance use and mood or personality disorders, or famously psychoses associated with substance use, and those disorders tend to emerge a little bit later. The other thing to keep in mind is that causality is difficult to assign because there is a lot of bidirectionality in the association between the two types of disorders. And another thing to keep in mind is that we may see early indications of these disorders during childhood or adolescence that precede a formal diagnosis. Particularly behavioural problems such as aggression or delinquency, young people's drinking or early cannabis use. These things can emerge during the late primary years or in early adolescence. So this slide shows the ages of onset, the typical ages of onset for common mental health disorders. And we see that neurodevelopmental disorders will often emerge around 12 or be diagnosed at that stage. And so we will see then anxiety disorders that typically emerge between 12 and 17. Eating disorders will also arise about this time, but may actually emerge earlier now. This work was done in 2022, and there has been a lot more work on eating disorders since then. But cannabis use disorder, which is typically the first one that emerges, or alcohol use disorders can emerge much later. And substance addiction typically doesn't emerge until the mid-20s. So we can see that finding comorbid expressions in early adolescence or in early adulthood can be a little bit problematic. The diagnoses might not arrive until later than the first symptoms. We're often asked about causal relationships, particularly around things like the emergence of psychoses associated with cannabis use disorders. But because of the different timeframes that we've just looked at and the sometimes lack of a diagnosis, a formal diagnosis, can make causal inferences quite difficult. And we use the longitudinal studies to try and determine this, but even so, there is a lot of heterogeneity in our populations. Some of the things that we think might contribute to the existence of these co-occurring disorders is the idea of people choosing to self-medicate around the mental health problems that they're experiencing with non-prescribed substances. And this can be using illicit substances, or it can be using treatments that are prescribed to somebody else. And our research in both the Global Drug Survey and in the drug trends will tell us that this happens quite frequently. It's also very often seen, as we are finding now, a lot of adults who recognize that they had symptoms of ADHD in their earlier life that weren't diagnosed, but the behavior and the problems that they have experienced, they have chosen to self-medicate those with other substances. But there's some very suggestive evidence. It's not conclusive, though, of a positive association between early childhood and adolescent anxiety and subsequent alcohol use disorders, where people use alcohol to alleviate some of the anxiety they have in social situations. There are a lot of family influences and environmental factors that come into play as well. So I'm drawing here on some of the work I did in my PhD, where I used a very large Australian cohort study, a longitudinal study, which followed families from the time of the mother's pregnancy through to the young people past the age of 30, and in some cases through to the next generation. And what we see is a very strong association between smoking and binge drinking during pregnancy and early childhood and the emergence of comorbid disorders in adolescence and early adulthood in their offspring. But we also see an effect for paternal smoking and drinking problems during childhood and adolescence. Now, this is more likely to reflect behavior modeling, so young people mimicking the behavior they see in their parents and taking that on rather than being a genetic influence. There are also important factors around how the family operates that can be influential. And one thing we found that was very important was parental warmth. So not necessarily the style of parenting, but we found that a strong, warm relationship between parents and children was very protective of the later emergence of comorbid disorders. On the flip side of that, we found that adverse childhood experiences and trauma and exposure to violence, particularly in the family, were very strong predictors of comorbid disorders later on. And of course, there are some shared genetic factors that predispose people to either substance use disorders or mental health disorders, but I won't discuss that in detail today because this is a complex field. It's not just the presence of a gene in our DNA, but it's how that gene is regulated that can be very important. And how that regulation happens is quite complex. It's a matter of both chemical and environmental factors that can be influential. So one question that's very often asked is which disorders are included in this comorbidity? And what we find in the large studies is that typically the most frequent mental health disorders are depression, anxiety, PTSD, and ADHD, with some very important emergences of psychoses and schizophrenia, and then more recently, eating and gaming disorders. Now, these findings have been quite similar across a number of countries. What does vary a lot more is the most frequent substance use disorders that are seen in conjunction with these. So quite often it's alcohol because it is the most widely used substance across the world. It's closely followed in many countries by cannabis and stimulants such as methamphetamine and opioids. And that will depend on which drugs are most commonly used within that country. So in Australia, as you would have heard a number of times today, we have a lot of alcohol use, but also their cannabis use is a lot more prevalent than other substances. The other thing to consider is that many people who use illicit drugs don't use just one drug. They will polysubstance use is very common. So some evidence that we have from our drug trends research, and we have two different cohorts here. Our EDRS is a group of people who regularly use ecstasy and related drugs. We used to call them the party drugs. And then there is another group who are quite separate, who are people who inject illicit drugs. So what we find is that the polysubstance use is common amongst both of those groups. At least 2/3 and up to 4/5 of them reported using at least two substances last time they used anything. And what we find is that at least half of those groups of people in both groups reported also having a mental health disorder in the last 6 months, but that only a proportion of those had sought treatment. So about 2/3 of our ecstasy and related drugs people, and about half of the people who inject drugs. And we will talk a little bit more later about why people do and don't seek treatment. So we've seen that substance use varies a lot between different countries and that mental health disorders are a little bit more similar in their prevalence across the world. So how often do we see comorbidity? Well, in general, we've come to expect that between 50 and 80% of people who have a substance use disorder have at least one co-occurring mental health disorder. And if we're looking at people who have mental health disorders, about 9% of these people also have a substance use disorder. However, there are a much larger number of people who report mental health disorders than who report substance use disorders. So overall, it looks like about, between 2 and 3% in the Australian population will have both substance use and mental health disorders at the same time. When I looked at the data for the World Mental Health Survey, the second survey for Japan, only about 5% of people reported having a mental health disorder. And of those, about 1/5 also reported having a substance use disorder. So the overall numbers are smaller, but the proportions are quite similar. They may be slightly lower in Japan, but that may also relate to both the prevalence of substance use disorders, but also the willingness of people to report substance use. In the United States, looking at a prevalence study from 2020 to 22, we see that about 1 in 4 people reports having a mental health disorder, 1 in 10 a substance use disorder. So if we're looking at the 50% mark, that looks at about 1 person in 20 in the United States who has comorbid substance and mental health disorders. Now that means there's a lot of people who need to have their comorbid substance and mental health use problems addressed by treatment professionals. And a lot of that need is unmet at the moment. So if we look also at the sentinel populations, which is our drug trends populations, like the Global Drug Survey populations, we can see that for people who inject drugs, the most common disorders are depression, anxiety, and PTSD. Over half reported having a mental health problem, and about half of those have actually seen a mental health professional. So these are people who all have substance use problems. For the people who use ecstasy and related drugs, the mental health problems are similar, but number 3 is ADHD rather than PTSD. And again, over half report having a mental health problem, but only about half of those, maybe a little bit more, have seen a mental health professional. And one of the issues that will come up later on is the resources that these two different groups of people have to access treatment. Typically, in Australia, people who inject drugs have lower levels of education, are less likely to be well employed, and so often have fewer financial resources to seek treatment. We find that this group of people here who are part of our ecstasy and related drugs study are more likely to have achieved higher levels of education and more likely to be employed, and so then have the finances to access treatment. So why is this important? Well, we know that mental health disorders contribute hugely to disability-adjusted life years across the globe, and this heat map, shows how this happens in different parts of the globe. We can see high levels of burden in Australia. We see quite low levels in Japan. So this was the 2019 data, and it's looking at the Global Burden of Disease study. What we do know is that typically people who have a serious mental illness die 25 years earlier than other people. Now, people will often leap early to thinking about suicide, but in fact, the primary cause of these deaths is pathology, other physical health disorders that accompany it, rather than suicide. And what we find in Australia is that comorbid mental health and substance use disorders are the leading cause of non-fatal burden on our health system. And they contribute about 24%, so nearly a quarter of the years that we lose to disability. So this has a big impact, not only on our daily life, but on our economy. How is it important for the individual person? What we often find is that people who experience both substance use and mental health disorders will often have a chaotic life because of all of these different problems. They will experience economic disadvantages because it becomes challenging for them to be employed or to complete higher education. They are more often involved with the justice system, so either interactions with the police or incarcerated. And quite often their background family will have lower levels of education as well, which makes it difficult for their families to address early symptoms of comorbid problems. The other thing is that they may have both lower financial resources and lower social capital to support their seeking of treatment or their engagement of treatment. So people may have lower levels of health literacy. They may not understand the health system as well or be able to navigate the complexities of our health system. In addition to this, we know from the large population studies that people with comorbid substance and mental health disorders experience poorer physical health as well. We know mental health disorders are associated with poorer physical health, but if we add substance use to that, it becomes worse again. So this means that the people who are experiencing all of these problems have more challenges to firstly recognise and then address, and they may choose to prioritise different issues when they are seeking support. One crucial factor is the issue of stigma. And this is a worldwide problem where people with mental health issues have experienced discrimination in many different places. This is moving forward with campaigns that are intended to improve our understanding of mental health problems, to normalise them, and particularly to normalise the importance of seeking support and expanding our health system to provide that support. But there is still a large amount of stigma associated with substance use, and that varies from country to country, but it is a global construct. But in countries like Japan, where the justice system is very strict about substance use, the attitudes towards substance use can sometimes become a further barrier for people to seek support. However, this is, as I said, not something that's specific to Japan. It's a very broad construct. The other thing is that much of the research shows that people who have comorbid disorders experience poorer treatment outcomes. However, I think there's an important caveat to add to this. When we think about the different areas of life, the different harms that are associated, we can see that these harms appear in different parts of life. So physical health, but also stress on relationships and families. There's an increased risk of violence. There's an increased likelihood of homelessness. Poorer mental health is obviously there, and the risk of self-harm and suicide is higher. Drug use severity is often higher when people are also experiencing mental health problems. But people's ability to function in a social environment and in their occupations and in the broader social environment is sometimes compromised. So it's challenging for people to engage with treatment, but there is very strong evidence that people with comorbid disorders are equally likely to benefit from engaging in treatment. So they will get somewhat better. The poorer outcomes that we see in the research may be strongly tied to the way that the treatment system has not been well set up to address the comorbid problems. And so the treatment models may not be well coordinated. And so that is, in fact, the source of some of the poorer outcomes from treatment, rather than the nature of the person. That's something very important for us to consider going forward. So how is this important for the services and the practitioners who are trying to address coexisting mental health and substance use disorders? Well, we have to admit that it becomes, these patients can be more complex to engage with. There are often behavioural issues that arise early in their lifetime, but may continue and make them difficult to engage with on a person-to-person basis. They may not, as we mentioned before, have the social capital, the understanding of the health system, or the resources to reach out. And so what we find is that the people who do engage with treatment are often people who are better resourced. And so the clinicians and the services become less practiced at working with people who have poorer resources. The other challenge is that by the time that it's important to note that it's not only the patients who experience stigma around substance use and mental health, but the clinicians who work with them can also experience that stigma as well amongst their professional colleagues and sometimes in the wider community. So this is very unfortunate, but it also means that it's an issue that clinicians need to be aware of. One of the other challenges is that because of the stigma that the patients experience, they may be less willing to approach treatment. And as a result, by the time they do end up in treatment, their situation is more acute. Their symptoms may be worse. They can be in a very bad position. And they will often present at an emergency department in a hospital rather than a community-based service that is geared up to deal with their substance use or their mental health problems. And emergency departments are really not set up to deal with acute mental health or acute substance use problems. So that becomes very difficult for the service. The other thing about an acute presentation is that they may turn up at another wrong service that isn't equipped well to deal with the problems that the person is presenting with. So that can be very challenging because the service says, I don't know how to assist this person. We don't have the right people to help you. This results in the person going, I can't get help when I've tried, and so they are more reluctant the next time to seek help. The requirements for the services are quite extensive because if people do have multiple problems, then multiple types of treatment need to be available to those people. And we have to think about, are the practitioners in that service appropriately skilled to deal with all of these issues? Are all of the different elements of treatment that are required available and accessible for the person who needs them? And it can be more difficult to keep a patient engaged with a service. So not only to start with, but to keep them there for the duration of treatment. And that can contribute to worse outcomes as well because they don't stay long enough to improve their situation. The challenges in retaining people can also apply to the practitioners, to the clinicians, because these patients are very challenging to work with, which can create stress for the clinicians and the practitioners, which means you sometimes have turnover of staff as well in a service. So what are the best models of treatment for people who have coexisting drug and alcohol and mental health problems? Well, we've seen in many, many places a sequential model of treatment. So the first treatment that's provided is the one for which the patient declares they have a problem or the nature of the service they've approached. If they're lucky, the secondary problem is identified and they will receive treatment afterwards for the second disorder. Quite often these services are separate and they operate independently with people not talking to each other about how treatment is being approached, and that can lead to delays and poorer outcomes, and the clients can become disengaged and become less motivated. A slightly better model is to run things in parallel. So at the same time, the person is receiving treatment for their mental health problems and their substance use disorders. But often these are still being provided by different services, which again might not be well coordinated. And so there's often a case where the patient feels that they have to contribute, they have to take a lot more time to contribute to their treatment because they're seeing one service for one thing and a different service for something else, which can then make it very difficult to them maintain their employment, for example. So it becomes harder for them to stay engaged. In the ideal world, we would have an integrated model of treatment where the patient benefits from a collaborative approach where they can see treatment for both types of disorders within the same service. They have a single treatment plan that notes all of the challenges that they are facing and how these are going to be addressed. And this will often involve clinicians from a range of disciplines, both the mental, the substance use, but also the physical challenges that they face. And this multidisciplinary team who is supporting them is coordinated, and it's all within the one service, or at least there's very strong collaboration and communication between the practitioners. And that allows for a more holistic follow-up as well, and continuity of support over time. The other issue that is important for treatment to consider is that these disorders, both substance use and mental health, are often relapsing. So people will improve for a while and then their condition may worsen. So it's important to have what we call a stepped care approach, which means that we can increase the intensity of their treatment and support when the person is experiencing more problems. And then we can take it down to a lower level of less invasive treatment or intrusive treatment when the person is doing well, but still allow for that continuity and realize that this can be a journey that goes up and down over time. So what things do we need to keep in mind when we're considering models of treatment? Firstly is the idea of the no wrong door. So in an ideal world, the person can present to any service, either a mental health service or a substance use treatment service, or ideally even a general practitioner. And that person, when they first enter the service, can address all of their issues. You won't have people saying, no, we don't do that here, because that's a big predictor of people's condition worsening. Another thing that is really helpful is to normalize the asking about mental health and substance use issues. And so, for example, in Australia, when one visits a GP for a routine checkup, they will ask some simple questions about, so how much alcohol do you use on a regular basis? How many drinks would you have in a regular week? And then they will also ask, do you use other substances? Do you smoke or use anything else? And because that's part of a routine checkup, it becomes more normalized to have that discussion about whether these things are happening. They will also ask, how is your mental health? Have you had any problems? And so these questions become less frightening, more routine, and people will start to recognize that they should be asking questions of themselves about this, and that this is a routine part of their health that should be considered. The challenges that we have to think about are privacy and confidentiality around whether or not people are comfortable to disclose their mental health or their substance use. And that will relate to some of the discussions that I heard earlier in the day about people disclosing substance use for fear of policing. Within a GP, obviously, these things are very confidential. With other services, it may be less so. The advantage of normalizing these questions is that if they become a routine part of our healthcare, that allows us to identify problems earlier, to start reducing the stigma across the population, because if everybody is hearing these questions, they think, oh, it's not something strange, it's something we should all think about. It also allows for preventative work to happen. So, for example, the GPs to take out some education of their patients to say, well, there are guidelines about what is a low risk amount of alcohol for people to use on a regular basis, or to talk about the risks that are involved with illicit substance use. And when substance use and mental health problems are identified early, then we have a chance to actually intervene earlier as well. So not waiting until we have somebody presenting at an emergency department with a full-scale psychotic episode, for example. What we then need is, if we're starting to ask these questions, is to have a holistic healthcare framework in our system that can assess the full range of health issues. And that doesn't necessarily have to be a massive screen for every episode. For alcohol, for example, with a GP, they can ask 3 questions to get a broad assessment of people's alcohol use that will give them some clues. And there are similar short screeners that can be asked about substance use and around mental health. And that allows the clinicians to think about mental health and substance use, smoking. And a lot of people who use illicit substances don't think about their smoking as well, but there were a lot of discussions earlier about smoking and vaping. It's also important for people to consider their diet and their sleep, as well as physical activity and their health behaviours. So what do they do to look after their health as well? And so early intervention allows those discussions about protective health behaviours to be had. We talked earlier as well about trauma, particularly in early childhood, being a strong predictor of comorbid alcohol, substance and mental health disorders. Because this issue will come up, it's important for the clinicians to understand this and to be able to work with people who've experienced trauma in a way that is appropriately supportive. Now, although we are looking also at system level things that need to happen for people to receive effective treatment, at an individual level, it's important for the individual disorders of a person to be considered so that we do the best treatment for them. If it's around cannabis use, it could be that we're thinking about reductions in use that will reduce the harm. If people are injecting opioids, for example, we can look at opioid substitution therapies or ways of reducing their levels of injection. And so making sure that the treatment that is prescribed is appropriate for the substance that is of concern. And then making sure that the treatment modalities are accessible for a patient. It's not helpful to say, oh, well, you would benefit from a 6-month rehabilitation program that you have to live in residentially, because that would be able to address all of your challenges. If somebody has a family or a job, they may not have access to 6 months of leave to go and do that. So we must think about other ways of addressing their issues. So outpatient channels, work in the community in group areas that are less public, don't require them to declare to the world, oh, I need to take 6 months off work because I need to get my drugs use treated. So we need to think about how people are able to actually physically and economically and time-wise able to access that treatment. And then we need to think about the integrated care plan for a patient that addresses all of the challenges that they have, so that we're not asking them to do one thing over here that would actually create harm over here. So, for example, we often use medications to treat mental health problems. If somebody is also using illicit substances, we need to think about interactions between the treatment that they are prescribed and other substances that they might be using, and whether or not there might be synergistic problems with that, or we might have medications working in conflict. So it's very important to have that breadth of view to understand all of the challenges that somebody is facing and make sure the treatment plan looks at all of these. The other thing that's really important, we talked about coordination and collaboration between different types of services being helpful, but we do know there is a strong evidence base that says if you can have those services co-located, so within the one location, you've got a much better chance of them actually being coordinated for the patient, and it means the patient only has to visit one service. The other advantage that we have noted is that because of the stigma around substance use treatment, if a service is signposted as a GP clinic or a mental health treatment facility or a holistic health support, then it is less stigmatizing for somebody to approach that centre for treatment and then within that centre receive treatment for disorders that they may not want to talk about in the general public. So much less stigmatizing than approaching a service that has a big sign out the front saying drug treatment here. And we know from our interviews with people who regularly use drugs that this issue of stigma and discrimination strongly affects their access to health services. So people often talk to us about behaviours, avoidant behaviours, so they don't disclose their substance use issues and only address their mental health issues, which is counterproductive. They may be slow getting to access the services. They might not attend follow-up appointments if they experience discriminatory behaviour from the service. And, for example, people may downplay their need for pain medications for their physical health conditions because they're afraid that a service might brand them as being drug-seeking. So all of these things then will contribute to a stronger impact on our tertiary healthcare system, so the hospitals, because of the later and more acute presentations that happen. And I know some discussions were had earlier on today about harm reduction approaches and how important these are to engage with people early about their substance use, but also their mental health issues. And so talking about reducing harm can sometimes help engage with people who might otherwise be not happy to seek support or treatment. They may not consider their mental health issues problematic or their substance use as being problematic. But if we can talk to them about reducing potential harms, then that gives us a gateway to talk to them and then subsequently offer treatment if it's needed. So I mentioned earlier the importance of including physical comorbidities in a holistic treatment system. So we need to think about combinations of treatment modalities that will address this constellation of needs. So pharmacotherapies are important, but so are cognitive behavioral therapies and motivational interviewing. And these can be used both to address mental health issues and substance use issues, but they can also be useful in helping address some of the physical health issues and lead to behavioral change strategies that can be addressing multiple types of health challenges. There's some good evidence that shows that adjunct therapies can be helpful as well, and that harm reduction strategies are very important. So as I mentioned before, interactions between illegal drugs and medications are important to think about. The accessibility for the patient of all of these different therapies is really, really crucial. And there are some very good opportunities now for internet or app-based delivery of these interventions, because that allows access to a broader number of people. It can be less expensive, and it can also be more private for people to access these therapies in their own home rather than having to physically approach a service. So what do we need to do to best provide this ideal harm reduction and treatment environment? Well, we need to upskill ourselves. We need to provide training for substance use clinicians in managing mental health disorders. And conversely, we need to provide training for mental health clinicians to manage substance use disorders. Because quite often people will specialise in one area and not the other. And what we tend to find is that in Australia there's been a very strong program of education for substance use clinicians to consider and address mental health problems, but there has been less activity around strengthening the capability of mental health clinicians to manage substance use disorders as well. We need to provide training for our clinicians on how to reduce stigma and how to address trauma-informed care appropriately. And it's very important for us to support these clinicians, to provide ongoing supervision of their practice, to guide them in best practice, but also encourage them to take time for their own self-care, because the issues of vicarious trauma and burnout and compassion fatigue are absolutely rampant in this field. So very important to look after the clinicians so they can look after the patients. And we can help these by looking at structural supports. So how does our overall health system support better coordinated treatment for people with comorbid disorders? Well, it's important for the system to ensure that the services that it funds and supports have the capacity to support and address both mental health and substance use disorders, and that can generate more of the no wrong door system, and to allow for links to other therapeutic providers to make this idea of coordinated, holistic, multifunctional care our treatment as usual. So communication, collaboration, and ideally co-location are really helpful. And if that can be supported structurally through funding, that can be really helpful. At government level, it's also important to have our policy and strategy documents recognising the issue of comorbid substance use and mental health problems, and making sure that the policies that determine how we work address these issues and support this coordinated approach. And we need at a society-wide level to address the issues of stigma, trying to normalise the need for support. And we can do that through public education. And we saw some presentations earlier on that talk about ways of educating our public on the needs for reducing harm. And the more we see these things, the more normalised they become. And other challenge that we can consider, and this is going to vary enormously from country to country, is, if possible, reducing some of the punitive approaches to substance use particularly. Now, in Australia, we have, as was mentioned earlier, a strong program of diverting people away from the criminal justice system if we can. So us offering people an opportunity when they are first picked up by the police for possession of small amounts of substances and diverting them into treatment rather than arresting them as the first course. So that's a very challenging area and will be contentious in many areas. I recognise that. There are a number of resources around that people can access to help with this upskilling, and I'm happy to share these links. And here I have a number of references that I've drawn from. But for now, thank you very much. Arigatou gozaimasu, and I apologize for my pronunciation, but please do ask me some questions. Thank you.